Good afternoon, everyone. Good afternoon. Nice chatty crowd. Everybody's feeling great. Weather must be nice outside. If I haven't met you, I'm Ebony Boulware. I'm the Dean of the Wake Forest University School of Medicine and the Chief Academic Officer for Advocate Health. And I want to thank everybody. It's so great to see students, faculty, researchers, clinicians, trainees, and many partners gathered here to explore and celebrate research. This event, this month of Celebrate Research of 2026 has been a month-long celebration through which we're halfway through to celebrate all of the discovery and innovation that's happening at the Wake Forest University School of Medicine and at Advocate Health. Throughout this month, we've been highlighting research, people, and partnerships that have advanced science and innovation across our communities. Research is how we make discoveries and how we move medicine forward and really make an impact on all of the individuals that we seek to help. It turns today's questions into tomorrow's care. And today, we're really excited to focus on cardiovascular research. As you know, cardiovascular disease remains the leading cause of death in the United States and a leading cause of death around the world. Improving cardiovascular health requires not only excellent clinical care, but also sustained investments in research, innovation, and collaboration, which is how we make the progress. Research not only helps us better understand the disease, but it also helps us develop the new therapies, strengthen prevention, and deliver care that's more precise and more effective for every individual. As the academic core of Advocate Health, Wake Forest University School of Medicine plays a critical role in advancing research that improves care across our health system. Our investigators are working across disciplines and across markets to translate discovery into meaningful improvements in patient outcomes. From clinical trials to population health research to digital innovations to new models of care delivery, our teams are advancing knowledge that improves cardiovascular health at scale. That's the power of an academic learning health system where discovery and care continuously inform one another. The theme of today's program is Beyond Boundaries, and that reflects the kind of thinking that drives progress in medicine. Breakthroughs rarely happen in isolation. They happen when clinicians, scientists, engineers, community partners, and others bring their perspectives together to solve complex problems. The work you're going to hear about today will reflect that collaborative spirit, from sports cardiology and community health to emerging technologies that are improving care for patients with heart failure. It's especially meaningful that we're gathering here in Charlotte at the Pearl, a place that's designed to bring together education, research, innovation, and our community. As our Charlotte campus continues to grow, it represents a very exciting opportunity to expand our research enterprise and strengthen collaborations across Advocate Health. Spaces like this and sessions like this help to create the conditions where our new ideas and partnerships can blossom and take shape. So today's program is going to feature several TED-style talks and a very enlightening panel discussion that'll highlight the depth and impact of cardiovascular research taking place across North Carolina and Georgia, and you'll hear, and elsewhere. You'll hear from investigators who are pushing the boundaries of discovery and developing new approaches to improving cardiovascular health. And that's why we're here to celebrate. That's what Celebrate Research is all about. So before I hand it off to our illustrious panel, I want to thank the organizers for Celebrate Research. That includes Drs. Lynn Wagenknecht and Christina Ferdouy, Ari Ball, and a whole team of teammates that have focused on this for over a year to bring these sessions together. So appreciate all of their hard work, and I look forward to enjoying the session along with you. So go ahead and take it away. Thank you so much.
Thank you, Dean Boulware. I'm Bill Downey. I'm an interventional cardiologist here in Charlotte. Saturday night, Mr. Johnson came in to the hospital having a heart attack, had this lesion in his right coronary artery, and treated it with emergent stenting to minimize the size of his heart attack and improve his long-term outcomes. He didn't have that heart attack out of nowhere. He had a long history of smoking, untreated hypercholesterolemia, untreated hypertension, but we don't spend time crying over that. That's where we start. We identify the culprit lesion, we fix it, and then we turn to systemic therapy. We can take a similar approach to how we think about disparities that arise in health and healthcare in our communities and in the course of the care pathways that our patients navigate through. I'll use an example today of atrial fibrillation care pathways that I and my team have been working on to not just understand that disparities exist, those are proven over and over and over within health and healthcare and society writ large. We don't need more data telling us that we have problems. What we need is data, and data that leads to successful solutions. Like we opened up that coronary, we fixed the lesion and addressed the systemic problem, not simply lament that we don't have total cures for atherosclerosis. So if we look at our atrial fibrillation population, if we look across the entire population of our catchment area of our health system here in Charlotte, 24% of the population is Black. We know that atrial fibrillation doesn't see the color of our skin. We would expect that 24% of the population with atrial fibrillation should be Black. Moreover, we should expect that as you progress through our care pathway, that same 24%, we'd expect 24% of patients seeing a cardiologist, 24% seeing an electrophysiology specialist, 24% ultimately coming to ablation would be Black. And in fact, that is exactly not what we see. We see at every step of the care pathway a continual decline in the percentage of Black people receiving care. In short, our care pathway is providing the friction that is driving progressive disparity. If we look at it not through a lens of race, but through socioeconomic status, we see exactly the same thing. No surprise. So what do we do about it? Well, first let's find the lesion. So the first thing we saw is that even after you see an electrophysiologist, we drop from 10 to 7% in patients getting ablation. Why is that? Well, there's potentially a lot of explanations. One, maybe it's conscious or unconscious bias. Maybe we're seeing meeting patients later in their disease where ablation's not an appropriate therapy. Maybe we offered ablation and the patient refused. Well, that would then beg the question, did the patient refuse disparately because of trust issues, because of communication issues? All of those could be addressed potentially, but we've got to know exactly what is the lesion. This is a diagnostic problem. So we've set up a standard note that all our electrophysiologists use to document on their consultation what I'm offering, and if I'm not offering ablation, why not? So that we can then turn that into data to make an appropriate diagnosis so that we can in turn treat the appropriate lesion. We'll see where that goes. But also we saw moving upstream in the pathway, we're losing people right at the beginning. Where can we address that? Well, if we remove steps of the pathway, we're going to remove potential friction points and potential loss points. So we put an electrophysiologist in a community access clinic, not only to see patients directly there and shortcut the need to see a primary care doctor, shortcut the need to see an adult cardiologist, but also to be there with providers and nurses day in and day out, linking with the community so that we build the knowledge. We also know that folks with limited access to our healthcare systems use EDs preferentially in the absence of an alternative. So we know that then there is a racial disparity in folks who show up with atrial fibrillation in the emergency room, more weighted towards Black people and the underserved. Okay, what can we do there? Well, we can say if you're seen in the ED and you have atrial fibrillation, we control it now, but on discharge, you skip the whole pathway and go straight to an EP. So we get evaluation straight away. Next, we can move even further upstream. One, we've got a lot of EKGs in the system. We are beginning to lay the groundwork for how we mine that EKG ecosystem to find out who has had atrial fibrillation that we didn't know, but we should reach out to. Maybe they didn't know, maybe their primary care didn't know, or they know once and forgot, and the things that happen in real life, but how do we bring the care to people? In addition, what can we do about finding people at risk, high risk of atrial fibrillation? You'll hear more. Dr. Abiljic has done great work on the library of 20 million EKGs we have here in the system, turning an AI model into predicting from a EKG and sinus rhythm to who will have atrial fibrillation coming forward. In short, we're trying to take an interventional approach to addressing disparities, just doing what we're trained to do. Find the lesion, treat the lesion, and then also treat systematically. One patient and one care pathway at a time, and then turn that knowledge not just into improvements in our care and our communities, but publish on it, teach the world how to do this, and hopefully make things better one lesion at a time.
Thank you, Dr. Downey. My name is Matt Goldman. I'm one of the vascular surgeons up at Wake Forest University in Winston-Salem. Thank you all for allowing me to come down to this beautiful space and to talk. Full disclosure, I'm a surgeon by trade. I spend most of my days unclogging, bypassing, and unfortunately sometimes amputating. What I'm going to talk about today is non-surgical, and I think is far more important than any of the surgical interventions that I provide as a surgeon. Peripheral artery disease is a progressive and debilitating disease of the lower extremities, affecting over 200 million people in the world. Prevalence of peripheral artery disease increases with age, we know that, but unfortunately, we are starting to see peripheral artery disease in younger patients due to comorbidities that predispose to peripheral artery disease, specifically diabetes, hyperlipidemia, and hypertension. The overwhelming majority of people with peripheral artery disease never need a vascular surgeon. The majority of patients with peripheral artery disease don't even know that they have the disease. So what we're talking about is a largely subclinical disease with huge cardiovascular outcome disparities. My next controversial statement, PAD is not a limb disease. PAD is a peripheral manifestation of a systemic atherosclerotic process, but it is an easy disease to screen for. The majority of patients, like I said, will never require surgery for their legs, and only 1% to 3% of patients with PAD will ever progress to limb threat from their disease. But 20% of patients with symptomatic or asymptomatic peripheral artery disease will have a heart attack or a stroke within the next 5 years. And most all of them that die with both of their legs. The risk of MI or stroke in a patient with peripheral artery disease is 3 times higher than non-PAD patients per year, and they have a 9 times higher likelihood of an MI or a stroke compared to their non-PAD counterparts. As surgeons, we love metrics. We like to look at our patency rates. We like to look at bypass techniques and stents and limb salvage. But when you look at what actually kills patients with PAD, the picture changes pretty dramatically. These are 2 very sobering plots that I want to walk you through. On the left, you see survival curves for many types of cancer, including less deadly cancers like breast and thyroid cancer. You can see patients with a diagnosis of PAD have a 5-year survival that is close to that of colon cancer. And people with a more advanced form of PAD or limb threat have 5-year survival rates that are closely aligned with those of lung cancer patients and even esophageal cancer patients. Now, if you look at the plot on the right, This looks at changes in 5-year survival in patients with different types of cancers over the past 40 years. Thanks to advances in screening, interventions, genomics, and medical therapy, including targeted immunotherapy, we've reduced the mortality rates for most cancers in this country. We haven't made a dent in the 5-year mortality for PAD in the last 40 years in this country. Did I skip one? No, there we go. All right. So let's look real quick. The American Heart Association comes out with guidelines for the medical management with people with cardiovascular disease. That includes statin therapy and anti-inflammatory agents to help reduce the inflammatory burden, which leads to atherosclerosis. 2 big studies that I want to show to you are from the vascular surgery literature. The first one was from the University of Utah, where they looked at Medicare claims data for all patients who undergo an intervention for peripheral artery disease. So these are people with symptomatic disease. And they looked at statins and their effect on amputations, which, like I said, we look at a lot of our metrics in terms of limb salvage. Interestingly, 26% of the patients in a large Medicare claims database were discharged on AHA guideline-directed therapy, meaning we missed on 74% of the patients who were discharged after an intervention. The second study on the bottom was one of our more robust PAD trials in the vascular surgery world. This was a randomized controlled trial, which we were a part of at Wake Forest, where we randomized patients to endovascular versus open surgery for their PAD. And again, outcome metrics being limb salvage predominantly. 25% of patients in a NIH-funded study looking at PAD were on AHA guideline-directed medical therapy during their trial. And soberingly, 50% were dead in 5 years in this trial, and that is a theme across all PAD studies. We looked at our data at Advocate. We took patients who went through our vascular lab with a diagnosis of PAD or an abnormal vascular lab study to see what percentage of our patients within our health network are actually on guideline-directed medical therapy. We found similarly about 23% of our patients with a diagnosis of PAD were on AHA guideline-directed therapy. And of those, 2,600 who had the opportunity to have their medical regimen changed based on their diagnosis of PAD, only 11% underwent a change in their medical therapy based on their diagnosis of PAD. So clearly we have the disease, and clearly we are not optimally treating the disease. There's a lot of limitations as to why, and the AHA is taking interest in this because, like I said, this is a growing issue in terms of cardiovascular health. The first issue, ownership of this disease. It's hard for primary care providers now to know the osteoporosis guidelines and the prostate cancer guidelines and AHA guideline-directed therapy for arterial disease. Outreach and screening is important. The picture on the top left is a group of our medical students. We were fortunate to get a grant 2 years ago to start community screening. Screening for PAD is much easier than screening for most other malignancies. It's non-invasive and it's low cost. And our medical students were able to secure a grant for us to go out into the community to do this. The goal is to get these protocols throughout all of our system and to get screening for PAD out into the community because it's an easy test to do to identify high-risk patients. Some of our other next steps, we've been fortunate up at Advocate to receive several NIH awards to help us to identify the molecular basis of peripheral artery disease. As I mentioned, in cancer, we've made a lot of progress looking at genomics and proteomics and targeted immunotherapies. In the PAD space, we've made none. We've been able to identify several gene sequences as well as protein sequences that are markedly different in the PAD population across the spectrum of the disease. What we're hoping to do in the future, unfortunately, we got a good score for some NIH funding to start to look at even at-risk patients to see if there are genomic or proteomic signals that may predispose people for early disease and get them into a care plan sooner. Some work's been done here in Charlotte. Like I said, most of these patients die from coronary disease or strokes, but PAD patients aren't like other patients. They don't exercise. They don't generate the METs to be able to necessarily have the typical anginal symptoms that most cardiac patients have. Dr. Arco's group down here in Charlotte has started a project where they look at FFRCTs to try to identify early lesions in patients who may benefit from preemptive revascularization of their coronaries. And we're writing a grant now to expand that throughout the enterprise. Finally, there's a lot of exciting work being done here through our Translational Center of Excellence to hopefully coalesce all of our resources so that we can make real-world changes. We have access to one of the largest granular data sets in the country and in the world of real-world data. So to be able to create data sets, including proteomics and genomics, is our goal, and also finding ways to use our vascular laboratory as a screening tool to identify these people before they ever need their first coronary or lower extremity intervention. Thanks.
Dr. Goldman, as an author on the PAD guidelines, I'm going to say that your talk was like a salve to my wounds. Thank you so much. I know. Hello, my name is Esther Kim, and thank you so much for allowing me to tell you about the iSCAD registry, an example of patients as partners in research. This is Catherine Leon. She's 38 years old. She's just given birth to her second son. 6 weeks at home, she developed some chest pain. It's worrisome. Her family takes her to the emergency department, but because she looks like this, a woman who's young with no cardiovascular risk factors, she's told it's not your heart. She gets sent home with an outpatient GI appointment saying, you need your gallbladder looked at. So she waits it out, but 6 days later, she has crushing chest pain while she's nursing her baby, goes down her arms. They call EMS. They took her to the hospital. She has a massive myocardial infarction and requires emergent coronary artery bypass grafting. She's reeling and she's asking questions. Why did this happen? But no one could answer the question. They say, get over it. You're lucky to be alive, because she keeps asking questions. They also tell her, what happened to you was rare, and we don't really know of any other survivors. But Catherine Leon is not someone who will sit down and take it, and she becomes a really important part of this story. What is spontaneous coronary artery dissection, or SCAD? It's a non-traumatic, non-atherosclerotic cause of acute myocardial infarction, secondary to intramural hematoma with or without an intimal flap. It turns out that the majority of patients with SCAD are actually healthy young women in the prime of their lives without traditional cardiovascular risk factors. It's also one of the most important causes of peripartum myocardial infarction. For patients, the diagnosis is relieving because at least now they have the what. But it's also devastating because they don't have the why or what now. Evidence for treatment is lacking. There is yet to be a randomized controlled trial in this disorder. And recurrence happens, but no one is really sure how often that happens. Cardiac outcomes are also only part of the problem here. More than a third of the patients have PTSD, but less than half get treatment for this. So Catherine Leon becomes a full-blown advocate. In 2009, she has gone online and she has found 89 survivors. And with those 89 survivors, she starts a SCAD registry. In 2013, she's founded SCAD Alliance, a nonprofit organization that looks to advocate for patients and educate patients and providers. She calls me up in 2014 and asks me to be on her scientific advisory council. Why? Because it turns out that SCAD is associated with vascular disorders the majority of time. And I'm one of the very few vascular cardiologists in the country. And I have a specialty in fibromuscular dysplasia, which has been associated with SCAD the majority of time. So we partnered together. In 2016, we come up with the iSCAD registry. And in 2019, on the International Day of the Woman, we enroll our very first patient. By the end of 2025, we have enlisted the help of 29 centers across the country and 1 site in Australia, and we've been able to enter almost 2,200 patients into this registry, which has been solely funded by the patient organization. From the very beginning, we engaged our patients. As we were putting together our questionnaires and our CRFs, we asked SCAD Alliance to post on Facebook, when thinking about SCAD, which of the following topics are most important to you? We had 421 respondents. In 2016, the papers in SCAD had probably about 150 patients included, so we knew that we were on the right track. As we were developing our network of SCAD investigators, the investigators also became advocates, and we started participating in the SCAD Alliance initiatives to educate patients via webinars, as well as inpatient symposia. So in 2023, we were very fortunate to host the 2023 Sanger-SCAD Patient Symposium, where patients from all over the country came to learn about SCAD from the investigators in the iSCAD registry. And while we were having this, we thought, boy, we've got all the best minds in SCAD research here. Why not have a think tank? So we did. And we talked about research advances, we talked about what's missing. And you'll note that the authors on this paper include Catherine Leon, but also Kathy Izzard, who was here providing support for patients, but her husband had suffered from a SCAD. We also highlighted the work of iSCAD because we include the patient voice not just by asking them what we should be asking of the research, but also putting them on the steering committee and asking them to be on the publications committee. We also make every single manuscript, even though it's very expensive, open access, because patients are contributing money, they're contributing their personal data, they're contributing their knowledge. They have the right to see the results as soon as everybody else does. We also ask patients to write patient perspectives in our larger manuscripts, and we acknowledge patients and their work in the registry in every single publication. But why do we do this? Because we don't know what we don't know. As providers, we tend to be a little paternalistic, thinking we do know. But what I think about when you ask me about what can I do after my SCAD isn't necessarily what the patients are thinking about. Additionally, when I see the patients in clinic, I think, how long do I need to continue with aspirin and Plavix? Should I start a beta blocker? What kind of testing do I need to do to figure out if they have a vascular problem? How often does this happen on a population basis, and how often will it recur? Is there angiographic healing? Is the ejection fraction going to get better? And patients may be asking this too, but they're also thinking about, how do I deal with my PTSD and the PTSD of my husband who had to do CPR? And they're preparing their families for potential sudden death. And they're asking, how do I be a parent while I'm trying to recover from this heart attack that came out of nowhere? So I started with the patient story, and I want to end with the patient story. And this is an article that was just published this month. I'm really proud of this paper. It is the largest series of peripartum cardiomyopathy in the literature. And a patient perspective was published inside the manuscript, and it was written by Lane Strukman. I'd like to end by reading this to you. It's difficult to describe what it feels like to believe you are going to die. My life until February 25th, 2025 was filled with love, adventure, optimism, and confidence. On that fateful morning, I was taking my children to school along with their new baby brother. My first time out of the house on my own with all three in tow. At the same moment, I pulled the car into the parking lot. My chest began to feel like it was ripping in half. I couldn't breathe, my arms were numb, and a sensation of panic washed over my body. We all know where this story leads. Thanks to a quick-acting school nurse, an ambulance was immediately called, and I was soon admitted to the hospital with a new and personally unheard of diagnosis, a coronary dissection. Landing at a state of acceptance has not been easy. I still talk to a mental health therapist weekly and pray each night when I go to bed that I don't die in my sleep. My greatest fear is that my baby, now 10 months old, won't have memories of me. But when I look at the brilliant effort of my surgeons, cardiologists, nurses, the love and support from my family and community, I know that my survival wasn't just luck. I am meant to be here, and so are the thousands of women, of mothers who suffer SCAD worldwide. Lane Strukman and Catherine Leon are why we do this research. Thank you very much.
What an honor to be here with these panelists, just incredible talks. Congratulations, everyone. My name is Dermot Phelan. I'm a sports cardiologist here at Sanger, and I'm going to be talking about sports cardiology over the next few minutes. 1986, Flo Hyman dies suddenly while playing a game of basketball. She was one of the most famous volleyball players in the world. 1990, Hank Gathers dies at age 23 on national TV playing a game of basketball. He was one of the most celebrated college basketball players at the time. 1993, Reggie Lewis dies at age 27 as a prominent NBA basketball player. Society turns to the cardiology community and says, what are you going to do to protect these young paragons of health. And so the experts of the day, this is a AI reenactment of them, but an accurate demographic, came together. And experts, but not athletes. And they came up with the Bethesda guidelines. And the Bethesda guidelines were the eligibility and disqualification criteria for young people with cardiac conditions. So these were a binary yes-no decision-making strategy that had been with us for 40 years. If you had a cardiac condition, you were allowed to participate in sports or not allowed to participate in sports. 2013, I was a young cardiologist at Cleveland Clinic trying to set up a sports cardiology practice, and I met a young African-American lineman who had a screening ECG that was abnormal and an echocardiogram and MRI that showed an increase in thickness of his heart, 13 millimeters. What is normal in a young athlete? Well, at that time, the only data we had in athletes was from Olympic Italian athletes, and this showed that this was very abnormal. And so the diagnosis was, well, this might be hypertrophic cardiomyopathy, a condition that could lead to sudden cardiac death, or it might be athlete's heart. And my recommendation at that time was to detrain, and I would reassess him. 2 weeks later, he tried to commit suicide. On a follow-up consultation with him, he basically told me that he could see no future, that he came from a very, very disadvantaged background. He was a football player, his whole life was built around football, and he felt that he was going to be disqualified for life. What did I miss? Well, we had no good normative data for this athlete. And all of the dialogue was talking about recognizing a potential risk of playing, but failed to recognize the definite risk of disqualification in this population. And we had no good data to try and quantify what that risk was. So I spent the rest of my career up until now working on these kind of questions. And one of the big issues is, what is an athlete's heart for various types of athlete? Not every athlete is the same. And some of these changes that we see where the walls get thicker, the chambers get bigger, can look like some of these diagnoses, this alphabet soup of conditions that are all associated with sudden cardiac death. So how do we differentiate these two conditions? Well, we need normative data. And so I'm very proud of the work that Advocate Health have done and we have done in various populations. Every year we run one of the biggest single-day screening events for high school athletes, Heart of a Champion Day. We look after all of the local high school and colleges, and we're able to get that data and use that as normative data. We also look after the local professional teams. Recently, the NBA approached us and said, we do almost 1,000 echoes a year on all of our athletes. Every NBA player in the league, every player in the G League and the WNBA get an echocardiogram. Can you guys do quality control on that? So we do that every year. I had a meeting with the NBA yesterday, just sharing all of this data. I'm the cardiology consultant for the NFL Task Force, and for over the past decade, I've run the NFL Combine. And we at Advocate Health now actually run the Major League Baseball Combine for the last 4 years. So finally, we have data in all of these different athlete groups. And there's obviously lots of other sports and lots of other people doing this research. But using this data, we're now able to publish guidelines that can guide us to tell us what is expected in an athlete and what is not expected in an athlete. What about the potential risk for various cardiac conditions? This was a young man that I looked after a number of years ago who had a sudden cardiac arrest on this track. This was his high school track. He was resuscitated successfully, had a defibrillator placed, and he presented to me asking, can I play? The Bethesda guidelines said absolutely not. But we put him in a registry, and the registry data actually showed, well, this is actually very safe to participate if you've got an ICD. And this story has been replicated over and over again. Athletes with long QT syndrome, Bethesda guidelines said absolutely not, you can't play. But we realized under certain conditions that it's actually very safe to do so. Same story with hypertrophic cardiomyopathy. We've actually realized for generations we've been telling this population don't exercise. And now they have all the problems of a sedentary lifestyle, and we recognize the actual benefits of exercise. Our lab, the Sports Cardiology Center here, joined with some of the major other sports cardiology centers in the country, And we looked at very elite athletes, professional athletes, semi-professional athletes. And these had all been people who'd been told that you can no longer play any sports anymore. Can you imagine the effect that that has on that level of an athlete? And so they were seen, went through a very detailed shared decision-making process. And in fact, the results were somewhat surprising. Many of these athletes actually, when they were the ones who were able to make the decision, themselves made the decision, you know what, I actually don't want to play. I don't want to participate. I understand the risk and I want to make that decision. It wasn't being told to them by someone else. But many did decide to play under strict criteria where we had very clear emergency action planning. And we found that the risk in that population was exceedingly low, exceedingly low. And so we've gone from using all of this collective data, we've gone from a period of almost 40 years where it was very much a binary decision of yes, no, you can or you cannot play if you have these conditions, to just last year we changed these guidelines. So this is one of the proudest papers I've ever been involved with. This is no longer eligibility or disqualification guidelines. This is clinical considerations for athletes with cardiac conditions, using a new lexicon for how we can actually address these kind of questions for young athletes, focusing on shared decision making, focusing on appropriate screening, focusing on emergency action planning. And so we published that in February of last year. Subsequently, a similar document for pediatric population just this week published work for combining the American College of Cardiology and the European Society of Cardiology, looking at masters athletes who've got a very different kind of risk profile. And coming up, we'll be looking at tactical athletes, the military, the fire force, police. They've got a very different algorithm that we need to think through. Using data from events like Heart of a Champion Day, like with our colleges, we're going to update the international ECG criteria for athlete interpretation, and these are criteria that are used worldwide. And finally, one of the things that I think is most important is the ORCA registry. This is the outcomes registry for clinical conditions in athletes. And any athlete who has a clinical concern can register in this just using this QR code. And we'll finally be able to look at these rare conditions, the SCAD patients that Esther looks after, and various other rare conditions where people don't know what level of exercise is safe to do. Once we can gather a registry that's large enough, we'll be able to answer those questions. And so to go back to my young football player, I'm happy to say that he did end up being diagnosed with a very mild phenotype of hypertrophic cardiomyopathy, but he had a very supportive team, and he ended up going on and playing D1 football and being very happy last time I saw him. Thank you.
Oğuz Akbilgiç. I'm a faculty at the Department of Cardiovascular Medicine. I do AI. And I try to do AI for medicine, actually. I separated from AI in medicine because when we do AI for medicine, we try to find the right AI tool to solve a clinical problem rather than developing an AI and try to find a medical problem to solve it. So that's why I want to start with a clinical problem that we are developing AI models to solve. The problem we handle here, we try to handle, is heart failure, which is a public health problem. In America, in United States alone, there is already around 7 million people affected by heart failure. And once they are diagnosed, 5-year survival rate is 50%. And it is a huge burden in the healthcare system with more than $50 billion direct costs annually. It is stemming from mostly like 1 million heart failure hospitalizations each year. And the most striking statistics to me is that in the entire nation, almost 50% of the US counties have no single cardiologist. It's a huge striking number. There are good news and bad news. Heart failure doesn't happen overnight. We don't wake up with heart failure. It goes through the stages. There are stage A. It's not necessarily heart failure, but we have risk factors for heart failure. Then it moves towards more like a early heart failure to the more advanced stages. Another good news is that we have all the diagnostic modalities that we can diagnose heart failure at early stages. But the bad news is that it can be very asymptomatic at earlier stages. And we don't have any population level screening for heart failure. That's why we usually diagnose them at the later stages, which is one of the main reasons that 5-year survival rate is really low. So that's why we need to develop some low-cost, scalable modalities to bring people in front of physicians for assessment of heart failure. That's why now we switched to electrocardiogram. Everybody knows electrocardiogram. It is one of the oldest, most well-known modality assessment of the heart health. And it is low-cost, it is scalable, and it is now on our watch. So it is very accessible tool. So now we are trying to see how we can use electrocardiogram to move our diagnostic time frame at earlier stages of the heart failure. So we started from the real clinical problem, and now we are going to use AI on ECG so to see if we can help solving this problem. So now we are talking about an AI model or deep learning model, take only single lead ECG that is found in our 12-lead clinical ECGs in the clinic, or in the can be recorded using the watch that I am wearing now, or many of you. And now imagine this model trained on more than 1 million electrocardiogram, where only input is the single lead ECG, output is a type of heart failure, in this case heart failure with reduced ejection fraction, let's say, and that model find those silent patterns that are not usually visible when we manually examine the ECG, but AI finds those patterns. And then this model, developed in Wake Forest, external validated in a completely demographics in Tennessee, and then blindly validated in a different country in Turkey, and also validated in a population level study where ECGs were recorded just because, for screening purposes, not for any clinical indication. So now we have a clinical problem needs to be solved, and we have an AI model that can detect this. And the very important thing is that when we apply this model to the patients years before ECGs, years before the diagnosis, it's still up to 3 years before, with the same exact accuracy, still identifies them as heart failure. So most likely, many of these patients have been living with heart failure until they get the clinical diagnosis. But now, what if we could deliver it at scale? Our watch already detects if we have AFib or not. What if we can detect heart failure from watch? This is also possible. This is the piece that we are working on right now. So we just need to fine-tune this clinical lead-one-driven model for heart failure by collecting more data, Apple Watch data paired with the echocardiograms. But this wearable piece is doable. This is another example how we are doing it. Natriuretic peptides are like a blood markers that are indicative of heart failure, has utility in the entire life cycle of heart failure. It can show the risk for heart failure, it can help diagnose heart failure, and also it can help identifying whether you already have heart failure, but whether it is worsening or not, whether you are in heart failure decompensation or not. The bold idea here is that if we feed the model with ECG, can we estimate BNP, a blood marker? The answer is yes, fortunately. And with really high accuracy, we can do bloodless blood tests. We can estimate the BNP from ECG alone. Now we also put it in a body. Now we have a mobile application that you record your ECG. It can take this waveform single lead data from your watch, run the analysis and tell you whether you have elevated BNP or not. On the background, it tells what your BNP is as well. But we recently got FDA breakthrough device designation. First recommendation was to use it for threshold, whether it is elevated or not. That's why our app is showing it's elevated or not. But in the background, it is actually estimating the true BNP value. But now imagine our patients who have consumer level devices, they record an ECG, and then we estimate their BNP. If this is a patient with no heart failure diagnosis, directly defer them to protocols. We already know what to do when BNP is elevated. if they already have heart failure, compare it to baseline. Is there a significant increase in their BNP compared to baseline? Yes, connect them to televisit. Maybe we can, a simple call, adjusting Lasix, maybe we can help reducing the burden in the healthcare system, reducing more readmission rates. But the feature what we are trying to do is that we can do that much from a single EDC. Imagine, what if I record the ECG, what if this ECG connects with my entire clinical history, my baseline ECG, it does the serial changes. Now we are talking about the AI model that does give a very precision medicine. It doesn't say that now your BNP is elevated. It is specifically because of my history. So now we are talking about the next level, much more accurate models that are clinically actionable. And this is my talk. I hope I didn't go over much. Yeah, thank you.
So Oz, that was terrific. My name is Jeff Rose. I'm the president of Advocates Health's National Heart and Vascular Service Line. And before I open it up for questions, I would just like to really recognize the panel for some really fantastic presentations. So we'll open it up for questions from the audience. So if anyone has any questions, please just raise your hand. But as we're gathering thoughts, I had the opportunity to review the talks last night, and I was really struck by the breadth of what's going on from what I would say is, the social science and the sort of how do we organize care to the patient's story and the primacy of that, and then really down to the basics and almost, if you will, the spooky of what we're able to now learn about our patients through these methods. And just to kind of open that up a little bit, Bill, I'd like to hear sort of your thoughts about this very common condition, AFib, that's if you will, hiding in plain sight. Taking better care of it is almost a social science issue, and sort of how do we think about that? I think about things like PCORI and other sort of avenues. How should an organization be thinking about tackling problems like this?
I think it's a good question. Dean Boulware has charged us to be the #1 organization of PCORI grants in the nation. And I think this type of work is exactly what PCORI is about. Closing the gap between what we know and what we do at scale. And I think when we think about an organization of our size, what do we have? Well, we have scale. And with scale, we can use that to solve problems at scale, and not only solve problems for ourselves, but teach others how to solve problems at scale. I'm looking at Yeniko Taylor behind. We have a similar project going on. We took a hypertension model that was meant to solve a local problem. People with uncontrolled blood pressure, more than 50% of people with high blood pressure in the United States don't have it controlled despite it being cheap and easy to do. Largely an implementation failure. Part of that's on patients, part of that's on providers, part of that's on just the system not working well. Nobody wants it to be that way. We stood up a remote telephone-based Bluetooth-enabled blood pressure cuff system, showed that it worked locally. That was great. Yeniko grabbed that. We partnered across the organization and turned that into a $10 million PCORI grant to say, does this work in underserved populations across North Carolina and Kansas? We will learn that. I heard yesterday that we are way ahead and completing enrollment months early, it looks like. It's fantastic. And I think a great story of how innovations in improving care at scale can in turn partner with the academic arm of our large organization, leverage Dean Boulware's challenge around PCORI to create the flywheel that will, I think, create an incredible opportunity for improving healthcare.
Yeah.
I'm really excited about this.
Yeah. No, I mean, I think, that story and the power of numbers, and that's something that, has been sort of one of the, sort of the core features as Advocate has come together, is the ability to really gain those insights and do them at scale. But there's also power in individuals, and Esther, when I think about what you spoke to, and Dermot, I'd like to hear a little bit more about where you see the role of registries. First, not just cataloging phenotypes and learning more, but sort of, if you will, registries 2.0. Where do you see this going, and how this would better help us take care of patients?
Thank you, Jeff. Registries are really labor intensive. And I think for a rare or uncommon disease, it's the starting point for research. It needs to be done right. The data has to be clean. The problem with administrative data is that if you have garbage in, you have garbage out, especially for a disease that's hard to diagnose. And so I think the way that we developed the iSCAD registry was absolutely necessary because we needed the clean data. At this point, we're now internet capable. I can stream a movie from Korea in 5 seconds. We should be able to democratize research. Patients who have been now adequately diagnosed should be able to fill in their own data. We should be able to pull in Apple Watch data. We should be able to use AI. We should be able to have our registry sit on top of our EHRs and extract the data for us. We should be able to work at the top of our license, as you and Troy like to say, and be the brains behind organizing that data, but we shouldn't be the ones at the computers entering that data. So bridging that gap between today, which is my research assistants and my research staff entering data, to what Oz is doing, is a little bit of a gap, but I'm hopeful we can get there.
So what do you think it's going to take?
I think it's going to take, it's going to take money. The world runs on money. Technology takes investment. And I think if we have a vision for this, there has to be mechanisms by which, when we purchase imaging modalities, like the PACS systems, we need to have databases behind it that are able to be mineable and marriageable, married to the EHR, and to patient-inserted data. And so it all has to be on the same platform, speaking the same language, and then derivable so that we can run the data and understand what it means.
That's fantastic. And so Dermot, on the same theme, and I really just commend the work that you and colleagues have done in sort of elevating the patient's voice in terms of their lives, their care, and sort of integrating that logically into insights that we can all use elsewhere. What's next? Where do we go from here in terms of this space, and how do we extend this to other populations?
Yeah, thanks, Jeff. I think I touched a little bit on that, and I'd go to what Esther was just talking about. I think, one, we need to get a better sense of risk for people when they're participating in sport. The reality is most people who participate in sport, even if they have significant cardiac conditions, do so in a very safe manner and actually is beneficial for them. So there's a small proportion of people that are higher risk, and we need to do better at being able to define who that population are, and that is going to come down to registry data. And I think the one thing I would add to Esther's point there is privacy. I mean, that's one of the big concerns, because we want to be able to leverage the wearable data. We want Oz to be able to go in there, look at the ECG, say, okay, you've got a population of 1,000 people with hypertrophic cardiomyopathy. Here's the 5 that are going to have a cardiac arrest in the next 5 years using some of this data, but it needs to be protected. And so I think that that's the first step in this. I think the population that is the most complex is actually the tactical athlete, is the military.
Yeah, that's
and
a term
and
I
police.
think most of us are not familiar with. Can you talk about
so the tactical athlete is really people who their job relies on for physical exertion. So, and oftentimes these are kind of burst physical exertions. So if we look at firefighters, take an example of firefighters, first responders or firefighters. Firefighters are significantly higher risk of sudden cardiac death and myocardial infarction than the general population, even accounting for all the risk factors that they have. And when does that happen? It happens when the phone goes off in the middle of the night, when the alarm is happening, or it's when they're actually fighting fire. And so it's that adrenaline, it's that risk modifier that we need to stratify. And so, again, I think that that's a population that has been grossly understudied and is a huge opportunity for us.
Great, thank you. So as we move from systems of care to patients, Matt, I'd like to kind of hear your thoughts. You know, obviously peripheral vascular disease encompasses a lot of that, but even gets down deeper, and you're talking about some really exciting work that's going on genomically and, you know, with proteomics. So could you talk a little bit about, you know, how we should be thinking about this more at a basic science level?
Yeah, no, I mean, I think obviously from my talk, we certainly need to be thinking about it on a population level first, because we are obviously missing the mark on that. But similarly to a lot of other disease processes, genomics and proteomics are at play in vascular disease. We just haven't figured it out yet. And I mean, you'll see a 60-year-old diabetic smoker with completely normal coronaries and carotids, and you'll see another 60-year-old diabetic smoker with terrible-looking carotids and terrible-looking coronaries and terrible PAD. So obviously genetics or the milieu, the biologic milieu is at play. And we've seen that in our preliminary data in the PAD population. And what we're hoping to identify are, number one, markers for who will recover from revascularization. Right. So looking at mitochondrial genetics, because that's the engine that helps with recovery. But also looking at protein markers or genetic markers that will potentially tell us who would benefit from revascularization is the first. But then the second is, you know, our data from Wake, which I didn't talk about today, shows that once you get people on the right, at least non-targeted therapies, so the statins and now the GLP-1s and the SGLT2s, if they are symptomatic from PAD, we've missed the boat, because their 5-year survival still is dismal, even when you get them on the right medical therapy. So using proteomics and genomics in the at-risk population, and the people with a family history, and the people who are in their 30s with diabetes or smoking, if we can identify predictors in that population of who is high risk to progress, then we can initiate, hopefully, targeted therapies. I mean, the ultimate goal would be targeted therapies, but that's obviously, we got to figure out what the right targets are first, which we are certainly in our infancy, and we've been fortunate to be able to continue to receive support for it, but we are still very much in our infancy at identifying which signals are the ones to go after.
Yeah, well, you know, you're bringing up a key issue with it, you know, we keep coming back to, and that's really getting upstream. I think I've heard that from all of our investigators. And, you know, Oz, you know, the joke is, if you told me in, you know, 2000 that from an Apple Watch I could diagnose heart failure, I'd say, what's an Apple Watch? Right? Right. So, you know, I mean, just, you know, clearly, obviously, we have such, you know, breakneck speed with technology and newer tools that allow us newer insights. And then, you know, to most of us, this black box, right? That you know, these tracings that we've been looking at forever that can now tell us our, you know, our chronologic age and whether we have heart failure and so forth. Unpack that a little bit for us and help us understand that a little bit more, because I think you've got, you know, 4 people up here who all want office hours with you to get your time for the latest and greatest application.
Well, I think the black box nature of AI is it's the biggest bottleneck. I was in Chicago yesterday giving a talk with similar AI applications. The first 2 questions I got was, what is the AI finding in ECG? It's a very fair question. And as data scientists, we do our best to explain, but imagine the AI takes this input image or ECG, turns it into like hundreds of thousands different nonlinear transformation, different dimensions. We are living in 3 dimensions, at time 4 dimensions. Like, we cannot comprehend that many dimensions. And then using analytical techniques, we try to understand which section of this ECG AI is really using. There are ways to do this, but imagine let's take it very simple. Questions like a AI model, just a square of a number. Result is 4. This is what we are trying to do when we do explainable AI. Result is 4. What could be the input? 2. Well, it could be -2 as well. There are 2 options. You don't know which one. This explainable AI gives the most likely one. Now imagine if there are millions of different alternatives that could give you this result. We do our best to explain, but sometimes it is just beyond our comprehension. The data it processes not the same data as well. Actually, I didn't even need to answer this question. Another younger cardiologist stepped out and said, well, there are a lot of unexplainable things we are doing. He said that we are doing pulmonary vein ablation. We don't know why it works, but we still do it because it helps patients.
Some idea. In fairness to my EP colleagues, we have some idea.
Basically, yes. As our role is to provide the most explainable AI models possible, but what if we have the 100% accurate, validated AI model that tells who's going to have cardiac arrest in 1 week? Are we not going to use this AI model because it is not explainable? Or we are going to do something about it? So I think our role is to do, when possible, to do explainable AI, but also accept that sometimes those models are just beyond what we can explain.
Sure, but maybe if you could comment, because I'm sure the audience would love to hear about this, about how do we protect against bias in those models, right? Because again, if the output's going to be empirical, right, in ways that we can't explain, but yet seem to be functional, how do we control for bias as we're building these models?
Yes, it is something we should be very careful. Actually, we are very thankful that we did this AI model for heart failure. Now, actually, it is in the implementation phase. But before we bring this AI model in front of you, we did so many different validations. So, because these models, they're on Wake Forest, right? But we didn't stop that. We didn't bring it to our leadership saying we want to validate it. We took it to completely different demographics. In Memphis, Tennessee, 65% African-American population. Model work with exact same accuracy. With similar accuracy for black, white, for young, for older. And then we did like a blinded validation, took it to a different country without any modification. And then we took it to population levels, like a rural health study we used where ECGs were recorded when there was no clinical indication. Model still works. I think there are a lot of work we need to do in the technical work before even considering it for implementation, because this bias, like you said, it is something that we have to be careful, because once you start implementing, you may think that you are helping with like the equity, but we may be worsening those like inherited biases if the study design is not really careful.
Yeah, and I think that that's for all of us on the the clinical side as these tools come out. I think that that's one of the cautionary tales, because we'll all read these articles about these wonderful tools in areas under the curve that are 0.9 and 0.95, but yet we don't know if it will work, more broadly. And I think that that's one of the other advantages that we have, in terms of the system. Just the 20 million ECGs linked to the clinical data does get back to the privacy concerns that Dr. Phelan brought up. But again, if we can find that right framework, it's really unlimited the sort of insights that we can generate. Again, I'd really like to thank our panel for really fantastic presentations, and thank you all for being here. One last round of applause.
Thank you all for coming. I just wanted to also recognize Brooke Martin, who helped us to organize this whole thing, as well as Ari Ball, who also helped to organize this whole thing. Lots of thank yous. Thank you, Dean Boulware, for being here today and introducing us. Just wanted to let you know there's a terrific poster session happening on the 3rd floor. So please continue this amazing celebration of research by joining us on the 3rd floor. Thank you all.